good seeing you.
Hello, hi.
Hello.
Hi Wilco, hi Thomas.
Hi John.
So perhaps I
Hello.
can fill the assembled multitude in on some exciting information. I mean, what's going on today is really something very special. Those of you who've taken part so far might like to know that 92 countries have been connected to us during the day, and in total we have just shy of 3,000 registrants for the Zoom room.
John, we've got no view of your beautiful face.
Haven't you? It doesn't matter, does it? Yeah.
No.
Okay, there we go.
I'm lip syncing.
You didn't.
I'm lip syncing.
You didn't want to see it. We've had 92 countries connected. We've got just shy of 3,000 people who are participating in the Zoom room today and tomorrow, and really, that is truly global. This is excellent, bringing everybody together. And I don't want it to put any pressure on anybody, because we're sending all the good vibes we can to poor old Wilco at Mission Control.
With Core,
he's operating
not alone.
about six or seven computers. Core's just providing a calming influence. What I can't understand is why Dutchmen only sit 1.5 meters apart and the rest of us have to be 2 meters.
Because the Brits are so much more snotty, John. That's why it is.
They are. Anyway, we're looking forward to a great final session today.
Okay.
We've got Peter Monkfield's just come on there, my colleague from the University Hospital in Birmingham. You saw that on the satellite view a few minutes ago, and he's together with Myrthe, also from the Netherlands. We seem to have got a good input from the Netherlands today. And,
Stop complaining.
This is the final
please.
session. Is the final session.
Okay. And we don't have Myrthe, but we have the father of BAHA, at least as far as I'm concerned. And I think it's the truth. That's Cor Kramers. So I'm not sure. Myrthe has not connected, but I know there are definitely some COVID issues now in the Netherlands playing. So maybe that's one of the reasons why she's late or not connecting at all. Nonetheless, we do have a presentation, and I propose to the chair to show the presentation first, if you agree. He nods. Okay, here we go.
Can you hear me on the
Yes.
link?
We can hear you fine, Peter.
Excellent. Okay,
Cor, maybe you can.
So
Peter, do you want to talk us through?
I haven't
Cor
seen this video presentation earlier on, so I'm not aware which type of surgery she will start to perform. What she made was already a linear incision, and she will show up now the periosteum, and we will see whether it has been cut into or not. And so she's now checking her incision of the periosteum, and she will widen it up a bit. So the periosteal flaps are put aside with a respiratorium.
Can you see, Chris?
She made a cross
Yeah, I can see
incision.
it. There are some questions about whether it's on full screen for everybody. I'm not sure. It is for me.
Well, that's in your hands, Chris and John. You need to put it always on. John?
Yeah, I've got that. It's just some
on,
people that
it's on full screen. They
there are
need to
some
click
questions.
on the mosaic at the top right-hand corner, and that should give them full screen.
The incision has been shown to be 2 centimeters about, and so she's exposing the bone for the implant to be placed. This is not the minimal invasion ponto surgery. It is just more classical small linear incision exposition to bring in first the hole to get the implant in, and as the text is saying that she is going for a 3 millimeter depth of the implant first, and to be not to hit into the sinus or dura unexpectedly. The hearing of the skin around shows it is an adult person, so the depth of 3 millimeter might have been also from the start 4 millimeter, but that's her decision. And she's explaining here that in the system there is a stop and that you can't go deeper into the bone than 3 millimeter. Now we see that she has chosen for the Oticon device. And in her clinic, the option for the cochlear BAHA or the Oticon Ponto device is given to the patient himself or herself. And since if you have the system from one company, like Cochlear, then you are sticked in next generations to their system and hearing aids. There is a point.
But if you insert the Ponto, you can use both systems if you insert the Ponto abutment.
Yeah, but there is an adapter to go to both bone conductors, but there is a battle, or there has been a battle in between both companies upon copyrights, whether it was allowed to have such an adapter, which is technically possibly to have a cochlear hearing aid or a Ponto hearing aid on a cochlear implant. But they have to stop to produce and to apply that adapter since there was a commercial discussion. Disagreement, for sure. There was a financial conflict. We see some darker color of the blood coming, venous blood. She has been feeling to see whether and to feel whether it is bone still there or not. The water cooling is essential not to get too many dead osteocytes, which are dead as a result of too much heating.
And that's all because of the osseointegration?
Yes, the osseointegration will be more difficult if the bony cells get dead because it was too heat. Now the flange is seen in the bone at this moment. I'm not aware that much anymore about the most recent system, whether the screwdriver has to go in to help to fix the implant too. There it goes. Now the low speed, because the final surface of the bone will be made now. And having a lower speed is controlling the heat that is produced too. Okay, this is a system where the implant directly goes in with the screw driving and it is already in place. The discussion has been whether in linear incision or not you need to take out the subcutaneous tissue. From origin, the abutment had a high of 4 millimeter, and in most patients, then the skin surface became too high, and that was the basis and the need to have a subcutaneous reduction. Nowadays, the abutment is larger, higher, and because they made those larger abutments, higher abutments, they could leave in the subcutaneous tissue. And there has been long time in fear from the industry that the longer the abutment was, the more risk there was would be to lose the implant. They have broadened up the system and the flange, and it showed, the clinical results showed it was stable and remained stable. And the results of not taking out the subcutaneous tissue is that you get less skin results and less neurologic results of pain, of numbness. And so the surgical technique has refined to have no subcutaneous reduction. The Nijmegen department where she comes from is still very close to the previous linear approach and incision to get everything well controlled done, and to be aware and supervising what you are doing in your surgeon, controlled by vision. That's their approach to prefer. So that's the demonstration, and we can give it over
to the moderator.
To the chairman. Yeah.
Hi, Nils. Good seeing you. Nils, are you connected from Hanover? One question. Okay, that's me again, I think. Or did you mute your audio?
Peter Monksfield.
Monksfield, can you hear us?
I can hear you very well, thank you.
Okay, so Nils, I think you have your microphone muted because it's not on this side. Okay, Peter, take it away. Otherwise, John will.
Great, thank you. I spoke to Myrthe before today, obviously, and she told me what video she was presenting. I haven't seen the video.
Oh, there she is.
Myrthe's on.
I am here. I'm sorry for the delay. Some technical issues over here.
Okay, we've seen your video.
Very good. I heard Cor commenting on it, so I was glad that he was there to take over my comments. Very thankful for that.
Okay, good. We'll be quiet now.
Would you like to make any more comments on the video, Myrthe?
Well, I guess a lot of them were already discussed, although I was only able to join during halfway of the surgery. So I think what we discussed on beforehand, Peter, was to mention that it's important to talk about the positioning and how to start this procedure with your measuring of the skin thickness. I'm not sure whether you've already touched upon that. So that's something I think that's important to discuss. And otherwise, yeah, I think the video itself was quite illustrative and some tips and tricks were mentioned there. Also, the subcutaneous tissue preservation is an important part to discuss, I think.
Yes, absolutely. So the video didn't really show much of the positioning, and we didn't discuss that beforehand. Where it sort of went straight into the video. But in terms of the preparation, assumed it was an adult patient. And do you routinely use local anesthesia for your adult patients?
Yeah, it's a good question. What we normally do is indeed use local anesthesia.
Just frozen there. The point.
Maybe if you ask someone else, Peter, whilst Myrthe's frozen, if you move on to someone else.
The point I was really trying to come on to there is around the use of local anesthesia and the skin thickness measurement and the key of making that before you've put the local anesthetic in. I can see Thibaud, you're on. How do you prepare the patient before surgery?
First, for anesthesia in adult I currently mainly use neuroleptin analgesia plus local anesthesia. It is an outpatient procedure. And the first step is to measure the thickness of soft tissues. The position of the implant is 45 degrees superior and posterior to the auditory meatus, with the dummy of the sound processor not touching the auricle. It's very simple to place. It's usually area without any hair, and so there is usually no necessity to shave the hair. And since 2012, I performed surgery only with a punch skin resection without associated incision. It was long before the MIPS technique, and now I use the MIPS techniques.
Okay. And in terms of the distance from the auricle, do you always use the dummy processor and get a clearance of a certain amount, or do you measure from a part of the auricle to the site of insertion?
No, I do not measure. The idea is that the top of the sound processor has to be at the level of the top of the pinna, and the sound processor has not to touch the posterior rim of the pinna. And I use for that the dummy usually to place the site of the implant. There is a little problem is that with the evolution, the sound processors are smaller and smaller, and the dummy do not change. And so the current dummy could let you to put the implant a little bit too far posterior, because the dummy is bigger than the current sound processors. The idea is that 45 degrees posterior and superior to the auditory meatus is the area where the bone is thick enough and where there is no hair, and where the sound processor will be close from the auditory meatus. It's good for the positioning of the microphones of the sound processor, and not too visible.
Okay, thank you. Nils, do you have any comments on positioning of the implant?
I'm sorry, I was just out. I had some technical problems, so I didn't hear what you were talking about before. So it's about the position of the BAHA, right?
Yeah. Yeah, we're just discussing how to prepare the patient on the operating table about where you're going to site the implant. And the discussion really currently is around the use of tissue preservation approaches, and so you know, deciding where you want to place your fixture and measure the skin thickness before using local anesthetic, and
of course
where you do that.
Yeah, we do CT scans in all of the patients before that surgery. So the one thing that you have to consider is, of course, the thickness of the bone. So in some patients, there are only some areas where there is enough solid bone to safely place the implant. And then, of course, it's if you have scarring, or if we do a lot of BAHAs in patients that had tumor surgery or radiation before, so you have to check the skin where it's possible. In cases where there are no restrictions, we go around 55 millimeters posterior from the outer ear canal, and try to place the implant there. And so regarding the soft tissues, what we did almost exclusively in the last 1.5 years in Hanover is that we use the MIPS surgery technique, because we believe that it's, and we made really good experience with it. And as we've heard before, you can use both BAHA and Ponto devices on the Ponto abutment. So we go for the MIPS surgery technique if it's possible, if we don't have to do an open approach. And we have really good experience with the wound healing afterwards because you have hardly have any wound.
Sure. And you sort of hi, Myrthe's back.
Yeah,
oh,
I was hoping that if it was possible to add some comments again.
Yeah, absolutely.
Well, I think it's very important, like was already mentioned, to decide the position and to stay as close as possible to the cochlea, which is indeed very important for the hearing. On the other hand, the device itself, it is getting smaller and smaller, but you need to prevent getting too close to the auricle indeed, in order to have the sound getting disturbed by the auricle itself. So it's important to make sure beforehand, with the patient, perhaps if they are they like to do horseback riding or something, so that they bring their cap, or they work in a environment where they need to wear helmets. So what I normally do is ask them to bring those within the OR, and to make sure that the positioning is not only based upon the measuring to stay as close as possible to the cochlea, but also to make sure that they can wear it in the environment that they prefer. And another important thing is, maybe we could go back to the comment of the CT scan, because I believe it's a little bit too much over diagnosis, since it of course incorporates radiance. And I was wondering, to maybe start a discussion, if you are okay with that, Peter, why would you do that? I mean, also in children, we use 4mm implants when the skull thickness is only 2mm thick, and we do not see any issues with that. So in adults especially, it's more important to decide whether the implant is in a position like I discussed before, rather than that the skull thickness might be a reason to change your positioning. I have never used the CT scan, and I have never seen any issues with that, especially since the adults normally have a skin thickness, or a skull thickness, I'm sorry, of 4mm. So it might be something to, yeah, of course, if you need a CT scan for another reason, then you can decide together with the patient whether it's feasible to do it. But if it's only for measuring the thickness of the skull, I think you should really reconsider that.
Nils, do you want to come back on
so
that?
if I might answer that. So I'm perfectly fine with you. You can do a successful BAHA screw implantation without having a CT scan before, but we see it more as part of the audiological differential diagnostic. And the patient often is not considered, okay, you come here, you get a BAHA, but we want to know, for example, if they have atresia, are there other options? What does the middle ear look like? Or if they have a single-sided deafness, we want to know, okay, is there any possibility for cochlear implantation? So they get like a whole test battery in our department, which includes CT scan and MRI scan. I have to say, we don't do CT scan classically. We do cone beam CT scan, and sometimes a little less radiance, yes, right. And sometimes patients, especially parents, are, as you, concerned about the radiation, of course, which makes sense in a way. But we say, okay, if you want to have a full diagnostic and have a full, complete counseling from us, then we prefer to have all the information about the ear that we can have. And so it's more part of the differential diagnostics than you actually need to do the surgery. Of course, if there are special cases like after radiation or something, we have to see what does the structure of the bone look like. Are there any regions where we feel that the bone is more compact and that might be more beneficial for the implant?
Yeah,
and just to add that we have, of course, cases seen where we need to localize the implant properly. So we have, for instance, patients after radical cavity. We have the emissary vein And we also have 2 or 3 cases where we got the damage of the dura and also some severe bleeding, with 1 case with epidural hematoma, 2 cases with meningitis following implantation. So, and when you look back or retrospectively where it was placed, then it's clear that the screw penetrated through the bone. So I'm advocating always to have clear information about the thickness and also the where you place it. So it's easy to measure just from your auricle, and then you know where the bone is thick enough. And especially in children, that is important too, that we really get this information in time for the surgery. So that's what I just would like to add. It's not only for the differential diagnosis, but also for the procedure itself. So, and to avoid those cases.
Yeah, I think it's important that you mention it. It's always important to have a broad look at things and to, of course, take everything into consideration. And I can really understand that you use the CT scan into the diagnostic tract. On the other hand, if you use the linear incision technique like I showed in the video of my just a few minutes ago, and you can really check the dura, although sometimes the bottom of the screw hole is of course bony, so it's not that you can see the dura or the sinus in most cases, but of course in many cases it is the case that there is a dura, so you can, even if you have an emissary vein and you put the implant there, the bleeding stops right away. Of course, if you see the dura, you really need to check whether there is the dura is still intact or there is a problem with meningeal fluid coming out. Personally, I have never seen a defect of the dura, but of course, you really need to make sure that's not the case. It's important to check, and therefore, I believe there is also a benefit in this open technique of the linear incision technique, because then you have really good chance to see and check the dura in the bottom of the hole or the other bone or the sinus, whatever it is, compared to the MIPS technique, which is of course even quicker, although it's not that much quicker, but you do have less sight onto the bottom of your drill hole. So you need to take this into account when you make your decision into which technique am I going to choose.
Is Javier on the call? At the moment? I can't see him on my screen.
No, I can't see him either.
We've got a couple of questions coming in, some on the chat, and we've just brought in Miss Submarinian. She's got a question, I think. I'll just open the line.
But John,
VJ
try to maximize
Lakshmi.
the picture as well, so we can see who's talking from the Zoom.
Yeah, a spotlight, yeah. So this is, it won't spotlight, the picture won't spotlight, I don't think. Hang on a second. I need to ask her to start the video. One of the other questions that's just come in is, a lot of patients complain bitterly about the sound of their hair rubbing against the implant. Do you have any solutions for that besides shaving all the hair away? Did you get that question?
Yes, yes. Thibaud raised his hand.
No, I just wanted to say that I have not this clinical experience from patient complaining from the noise of the air. So I have no solution for that. But in France, patients do not complain of that.
Okay. Vijay Lakshmi, would you want to ask a question? We can see you on the screen.
Yeah, I have a question.
Go ahead.
I do have.
Welcome.
Can you hear me? Can you hear me?
We can hear you.
Yeah.
We can hear you. Welcome.
Yeah. Yeah, I'm speaking from India. I'm Dr. Vijay Lakshmi Subramanian. You see, these are recent advances, and not everybody in India has got exposure to these advances. May I request the panelists to give a very basic information for the benefit of everybody who's watching on BAHA, as well as what are the limitations of BAHA, and why do you prefer BAHA over a regular hearing aid? These are very basic questions, but honestly, I have to ask.
That's absolutely fine. The whole idea of this transmission is that we cover everything from basic questions to complex ones. So perhaps if we hand that over to Peter to bounce that one around.
don't get me wrong, because I come from a developing country where we don't have access to so much of learning resources. And not only
Absolutely,
me,
sure.
a large number of ENT surgeons are totally unaware and they don't have access to learning all this. Thanks to the Lion webcast, at least you are coming to know about it. So, it's not good to pretend that we all know so much. To ask you a complex question, I don't know the basics. How can I ask a complex question? So
We're
I just want you to
very happy with the question.
speak
Thank
in
you
a
very
very
much
basic way.
your question.
That
Okay,
help
John.
me to get motivated.
Yes.
Thank you very much.
Okay, we'll cover that. Thank
John,
you very much.
Change spotlight, please.
Okay. So thank you very much for your question. I mean, my first response for any hearing implant is conventional hearing aids should be tried first, and it's really only the place for surgically implanting something for hearing because of failure of conventional hearing aids. But there are sort of specific indications for bone-anchored hearing implants. Which I don't know where we want to start. Myrthe, would you like to start answering that?
Yeah, I totally agree with you, Peter. It's of course once a patient is able to wear a conventional hearing aid, then you should go for that. But there are many cases, for instance, the conventional indication, which was the ones that we started to use this 40 years ago, were the ones that are having recurrent otitis externa, external otitis, I'm sorry, due to these conventional hearing aids. And for those patients that is not treated, that we are not able to treat it, then you can go and switch over to a bone conduction device. But you must be sure that your bone conduction thresholds are good enough for this solution. And of course, you need to make sure that you have an audiological department collaboration to together make sure that these patients are being taken care of. So there needs to be a close collaboration with you as an ENT surgeon and your audiologist to make sure that you have the facilities to follow them up in your clinic and to make sure that the implant can be checked when that's necessary or even regularly. And also you need to have the software updates or settings that you need to make sure that you can provide this to them by means of this audiological center or an audiologist in a different city, of course, but that's depending on how it's organized. So once you have these facilities, then you can, from the conventional indication, there's of course also the extended indications, which have been coming into the podium after a few decades of usage. So then you can think about the ones that having a unilateral hearing loss with a very large air bone gap, in which you can experience as a patient that you provide better benefit or more benefit from a bone conduction device compared to a conventional hearing aid. And the same accounts for single-sided deafness. Of course, this is a very difficult area to cover in a few minutes. But if you talk about the basics, then you should start with the conventional indications. So the recurrent infections or the microtia cases, of course, in which they do not have an oracle to wear their conventional hearing aids on. Is that a little bit what you were hoping to hear from me, Peter?
Yeah, that was very, very comprehensive. Thank you very much. Can I ask any of the other panel members if they wanted to add anything to that? Nils, Thibaud? Nils?
Yes. So
the particular position of the bone-anchored hearing aids that they provide a solution where, for some cases where there is no other solution. That means all chronic otitis with unstable middle ears, where you cannot repair the conductive hearing loss by surgery, where you cannot use air conduction hearing aids because the middle ear is unstable. And this is a particular place for the bone conduction hearing aids. And in that cases, they are extremely efficient and well tolerated. And these indications are really the basis for bone-anchored hearing aids. They are unreplaceable for that cases.
Mm-hmm.
And I would speak of, perhaps we will speak of that later, a second thing, which is the tolerance of the bone and cord hearing aids. In my opinion, the tolerance of bone and cord hearing aids with percutaneous implants, the BAHA and Ponto, is really, really very good, with 80% or more of the patient having good skin tolerance, with a rate of implant loss inferior of few percent, and they have a false reputation of bad tolerated techniques. And I think we have to educate the patients and the audiologists to teach them that it is really well tolerated hearing solution for patients who have no other solution with hearing aids.
I think Thomas is itching to make a comment.
Yeah, well, just to make a comment on that. I'm a bit surprised about your comment on southern France. So I heard from Jacques Magnon telling that he should not even mention a BAHA to a patient. He would run out of his office because the cosmetic aspect is so terrible. Now we somewhat have the same, though the rate of acceptance for a BAHA in Germany is very low. It has changed with the transcutaneous systems, where the patient basically has not a visible screw on his head. And this is also backed and supported by our data on complications and infections. And so we can say that overall complication rate in our BAHA population, somewhat like 180 cases, is about 20%. So the loss of implant is more than 10%. Compared to the bone bridge, where we also have now experience of several years, where we have a complication rate that is much lower. It's below 5%. And we see some skin issues very rare compared to the BAHA. So especially also in children, where we have this problem of physical exercise and breakout of screws, etc. Well, this has been a major step forward also for the acceptance of these devices, even so they are bigger and they have some disadvantages such as MRI compatibility. But I think that's something one really has to look at, that this has changed the field to going towards the transcutaneous.
Yeah.
We've got another question that's come through the chat saying, what's the approach of the panel to soft tissue chronic infection and purulent discharge around an abutment if the routine steps fail?
Maybe I can take that, Peter, if that's okay with you?
Yes, yeah, I sort of dropped out from the other connection. I've come back in on Zoom now.
Okay.
So,
Okay, perfect.
Well,
I think what Professor Lenarz mentioned about the complication rates regarding implant loss and skin issues, and the fact that it's so different between centers or countries. We currently have been writing a review, especially in children. The numbers are higher than in adults, as we all are aware of. But still then there is a large difference between different centers. And I still think it's important to really look into your own data and see how you can explain if it's different from numbers that are mentioned in the literature as well. I'm not sure what it is explaining the differences, but they are pretty large. And especially if you look into the skin issues, like Professor Lenarz says, more than 20% in the percutaneous implant. That's far much higher than we experience in our center. And of course, maybe it's the Dutch population, maybe, I don't know, the way they take care of the implant, the way we have scheduled a regular visits. And in case there is a discharge, the question that was asked through the chat. So what we normally do, we check the status of the skin by means of the Holger's classification. But nowadays we really prefer the IPS classification, which is a scale describing the inflammation, the numbness, and pain. So the P from pain and the S is skin issues. So if you check that scale, it's available online. Then you can also see a treatment advice. So you score all these 3 items and you come automatically into a treatment advice. And what we normally start with is an antibiotic ointment to use for at least 7 days, and preferably a little bit longer, because we have the experience that patients normally use this terracotril ointment, for instance, until the discharge stops. And then the infection comes back because it wasn't long enough. So we really argue to them to use it for 7 or maybe 10 days, but at least 7 days. And we also have some advice about their hygiene. So some people still use the cleaning instrument that was provided by the companies, like a toothbrush. So they really scrub the skin around the implant. I do not know if that's the case in your country as well, but we do see a lot of issues coming from that. So we really advise them to gently clean it with a soft wipe, for instance, or and only once a week, not too much. So maybe those advices can also help to prevent discharge.
Yeah, and I'd entirely agree that the rates of skin reactions in the sort of 20s, 30% are much less these days, using tissue preservation techniques and having healthier skin generally. But yeah, and I entirely echo the use of topical antibiotic, steroid, and cleaning as the first port of call. Any comments from Nils? I guess your experience may be very similar to Thomas.
Yes. But I mean, you have to. I don't know what regarding the question. I don't know what you mean with standard care. I mean, of course, if you try to make it clean, and if there's granulation tissue, you sometimes need to reduce it with, I don't know, silver nitrate or whatever you take.
Yeah.
But at some points, and the more often you do the BAHA systems, the more often you see it, you have to say, okay, it did not heal in, and you have to remove it, unfortunately. I mean, it always hurts a little, especially the patient, of course, but also the surgeon. But yeah, that's, as we've discussed before, that's one of the disadvantages of that procedure, that you have these complications.
And if you have to remove the abutment, what would be your management with that patient then? How long would you leave it? What dressings would you use? And when would you consider putting it back in?
Nils,
in case of abutment removal, it's the whole heals in few days just with antibiotics and steroid ointment. It's very simple.
Yeah. If you have to remove the abutment, normally we try to remove it for a reason that they would like to stop using the device. So if they have a lot of problems with discharge, we actually never choose to remove the abutment temporarily and put it back when it's healed again. So what we normally do, if the advice is like Nils already said, with the silver nitrate, for instance, or antibiotics, we put back the healing cap with the terracotril gauze again around it. So that's a step that we additionally might take if it's really getting a problem, and even use oral antibiotics in collaboration to do it both. So, but if you remove an abutment because of non-use, for instance, or they have just too many problems and they want to get rid of the device, then we normally see that the skin is closed. You can remove it in your outpatient clinic without any problems. It is easily removed and it is easily closed, the skin. We provide them with terracotril ointment for a few days, and then the skin is closed. At least that's our experience.
Yeah, I would agree with that.
And to come back
any other comments
the discussion
on sort of surgical
with
treatment?
Thomas between transcutaneous and percutaneous hearing devices, if there were magic stick. Sure, transcutaneous are better because there is no skin issue, but the cost of these transcutaneous devices is very, very higher than the cost of the percutaneous. And so in a country like France, for instance, there is no real competition between the two. The percutaneous bone and cord hearing device are fully reimbursed by the National Health Insurance, and transcutaneous are not reimbursed. That means a bone bridge cost is around 9,000 euro, and a Ponto or BAHA has no cost for the patient. There is no real competition between the two.
But that is this is a direct cost. But the indirect cost, what you told me, that you need this kind of frequent cleaning and all this aftercare. Patient has to come. You have travel costs, etc. All this keeping in mind, and then you look on this, and also the BAHA screw is for the health care provider not very cheap. Yeah, so if you come for lifetime costs, probably is not much difference. But the comfort for the patient, the quality of life is much different. So in our country, the transcutaneous is reimbursed. Sometimes we have to fight for it, but it has really improved the situation quite a lot. So that's what I just want to say. And all the companies, also Cochlear, is going for a transcutaneous system. It's not the BAHA track, but it's the OCR, and also Oticon is developing a transcutaneous. And the question is, why do these companies do it? Because they know about the problem of percutaneous systems, and that's the reason why they aim for it. So that's what I get from this development, and it's probably, if it's possible, that we can place it in patients, then I think we should do it. So driving it forward. The BAHA is effective, yeah, that's true, that's no question. But the given situation with kind of aftercare needs and complication rates basically says we need something better.
Can you hear me? I'm having a problem with my microphone, but we've had a poll while this has been going on, and I think that the majority of us would accept that there are some very good indications for BAHA, particularly trying to rejuvenate chronic ear disease when the results of vesiculoplasty is universally bad. What's the opinion of the panel on BAHA for otosclerosis? Peter knows that's a contentious political issue in the UK, in that I offer all my patients BAHA as an alternative, a safe alternative to otosclerosis, but it does have these other problems. How do you counsel your patients about their options?
I propose that, to the patient the surgery, air conduction hearing aids and bone conduction hearing aids, and I use a Ponto or BAHA or the headband to show them what could be the improvement by reduction of the bone conduction component of the hearing aid. That means that there is a double interest that show them what hearing could provide the bone and cord hearing aids, but also that shows them what improvement could provide the cure of the conductive hearing loss by stapedotomy.
And what is the uptake in, well, you're in a very unique situation as you have Napoleon Bonaparte next door to your office. I presume that the patients in Colombiers are very aware that there are the two options. What does the French patient tend to opt for?
Oh, surgery.
Only in terms of otosclerosis.
Well, when they have the choice, they are quite always choose a stapedotomy.
Yeah, I mean, I have to say in my practice, I wouldn't routinely use a headband trial or a bone conduction hearing aid in the workup of an otosclerotic patient. And although would mention it alongside conventional hearing aids, it would not have or press them into trying a bone anchored hearing aid before going for stapes surgery. What would you do in Nijmegen, Myrthe?
Well, it's a little bit like you say, Peter. It's we do discuss it. We have a complete package of alternatives that we discuss with our patients. And we do have the experience that most of them prefer a stapedotomy, to have surgery, to have no hearing aid visible. But if they are in the waiting period or they are not sure what to choose, then we indeed offer them a conventional hearing aid trial in combination with the offer of a bone conduction trial. So we have this step in between with the test rod, so to speak. So in our outpatient clinic, we can let the patient hear it for only a short amount of time. And if they have the feeling that they would like to try it for a longer period, then we will provide them with a trial, but it's not necessarily that they have had this trial for a longer period of time before they enter choosing the surgical option. So it's more or less the same as you say, Peter. And maybe if I may, but I'm not sure, maybe you want to continue this discussion first, because I also wanted to say something about the active-passive transcutaneous devices, but I'm not sure what you prefer as the chairman, Peter.
Well, you've got the floor at the moment. Why don't you make your comment?
Okay, so I shortly wanted to address about the transcutaneous devices and the cost benefit. It's something that is pretty difficult to really address in this, especially in this area. We have been trying to assess the cost benefit for the different implant types in the past years. But if you want to compare it to the transcutaneous options, then of course you need to take a lot of items into consideration, and it's very interesting to have this discussion. Of course, we do believe it's different if you have the transcutaneous active or passive. So Professor Lenarz was mentioning that the active transcutaneous devices are the ones that the firms or the companies are going forward with, and I do believe this is because of the drawbacks that we all know of the percutaneous implants, but I also believe it is because of the fact that they would like to have alternative solutions for their patients. Everybody is unique and has different habits in life. So, for instance, if you come from Sweden, where they produce these devices, it's more cold, so they like to wear helmets, or like in the winter when it's cold. And this is also a reason to go for these active transcutaneous devices. Since the passive ones, you lose energy. So they had a solution to overcome this audiological loss of energy by means of an active device. And this is also why studies showed that the more close to the cochlea, the better the outcomes. So in my opinion, we also still need to take a look into why are these numbers of implant losses and skin issues so different in different clinics, and how could we try to improve them and to get them to a lower level, since over the past decades we did see that it's getting better and better.
The other sort of point on the sort of transcutaneous percutaneous debate is around MRI scans as well. A significant proportion of patients need an MRI scan at some point, especially if they have a tumor in the ear or previous cholesteatoma surgery. They may want a diffusion weighted MRI scan, and the transcutaneous devices are going to create, even if they are MRI compatible, create a huge artifact
scattering,
which you don't get from a percutaneous device. Nils, did you want to comment on otosclerosis and the use of bone conduction or bone anchored hearing implants?
Yeah, I was just saying you have to consider the hearing on the other side. I mean, if a patient shows up with a unilateral sound conduction hearing loss, then we wouldn't recommend a BAHA or anything, because stapes surgery is quite a safe procedure, and you can also have the problem with overhearing on the other side. So if we have a mild, let's say 20 dB bone conduction threshold on the ear and a normal hearing on the other ear, then that's may have the disadvantage that the patient hears on the other side. And I remember one patient that was deafened by a stapes surgery like 20 years ago, and he was scared to do a stapes surgery on the other side, which of course I could understand. And in that patient, we did a bone-anchored hearing system. So that was an example that there are always some cases where even in otosclerosis, the BAHA solution makes sense. And of course, it's a question of availability of good stapes surgery.
I think the problem we have is that some patients are extremely risk averse, and some patients are prepared to take a small risk. And we say stapes surgery has no risk. I mean, I get good results. No. I use Robert's technique, as you'll hear tomorrow, but I do get failures along with the other surgeons present here. And you will get the patient who comes along occasionally who says, I do not want to take any risk. And I personally feel you've got a duty to at least offer them a BAHA as a possible treatment, although I appreciate the costs of that. And that's really what's happened, I think, in the UK, is, they're offered a conventional hearing aid, they're told the BAHA is a possible solution, or the stapes surgery, but those in the know will pick their surgeon. But we've got to accept that even in the very best hands, there's probably a 0.7, 0.8 failure rate. So it's the patient who has a risk aversion that I think they're very few and far between, but it's worth considering for them.
John, if you name that percentage, you mean central neural hearing loss, but failure rate is higher than that. I mean, failure rate failing to make the hearing better is not 0.7.
But that's not a risk, Wilco. Sure. Failing to make the hearing better doesn't leave them any worse. But if you give them a dead ear or a sensory neural hearing loss, you have done them harm. It may not be intentional. Whereas if you offer them a BAHA as part of your discussion, and they go for that, they have been done no harm. So I certainly think we feel, I don't know what the teaching is now, Peter, but I certainly feel it's something I do offer them, and I put a paragraph in the letter saying they have been offered the following options, sent away with internet advice and told to come back and have a further discussion when they've looked at the risks and considered for their lifestyle which is most appropriate. And I think then you are also covered at a later date to a certain degree from a legal point of view and a moral point of view, that you have covered everything.
I don't know if I can come in. I must say I don't offer them a BAHA. I offer them a conventional hearing aid. If they got a dead ear, of course, then you could offer them a BAHA. That'd be good. But I don't do it up front. I think a conventional hearing aid for most patients is going to be a good option for them if they don't want to have stapes surgery. The BAHA, perhaps, if they've got more severe mixed loss, but I think most of them, if they, in my experience, if they're risk averse, they don't want surgery, they're going to have a hearing aid. If they're happy to have surgery, they're going to want a stapes. I don't know if there's anyone got a very different experience to that.
Well, I think the question is whether the patient wants to go with any kind of device or whether he wants to be device free. Huh?
Without.
So if he without anything, and I think that's what we have to tell him. So you can stay with the device, that's safe, gives you some hearing. The quality is probably not the same as with after stapes surgery, provided there is no inner ear loss. And I think that's a part of the counseling. Now, which type of hearing aid he uses is also the second question then. Is it conventional or is it the bone anchored? And then, of course, the patient has to make his kind of judgment, I think, about what he wants to wear. And also you can try it. You can try a acoustic hearing aid. And then you also can use the BAHA headband and give him both and see which one he prefers in terms of sound quality, comfort, etc.
The question I was wondering just from the panel is, of those who choose not to have surgery, who want a device, how many people will end up with a BAHA as opposed to a conventional hearing aid? Because it's not really something I particularly offer. So are the people out there where lots of their patients end up with BAHAs, or is it a very small minority?
I mean, if I can come in, I would say a very, very small minority. I mean, certainly in a centre like mine that has a large bone-anchored hearing aid series, very few otosclerotic patients are going for a bone-anchored hearing aid now. You know, these are usually patients with completely normal ear canals, normal middle ears, other than their otosclerosis, of course, and you know, tolerate a conventional hearing aid very well. And so they would go down that line first, and that's, I think there's few these days. But I don't know about the other panel members, if they've got any comments. Thibaud, you're raising your hand.
Well, I think, Peter, your comment these days is the important one. That's a very mature approach, but you know, in the past, if we go back 20 years, you know, that wasn't the case, and in fact, the results of stapes surgery weren't that good. You know, things have improved, and I'm really pleased to hear that. That's interesting. I don't know what the others feel.
And the evolution is that otosclerosis is diagnosed earlier and earlier, and we operate patients earlier and earlier. That means that after the surgery, they do not need any more hearing aid. And in that case, the choice is really surgery and then no hearing aid versus hearing aid. This is not if, as they have severe mixed hearing loss, where the choice should be surgery and then air conduction hearing aid versus a BAHA on the other side. In our practice, currently, patients operated on for otosclerosis have mild to average hearing loss, and so no more hearing aid after surgery.
I think there's one other solution out in the market, that is the adhere, so that you can probably also serve patients who have just a mild conductive loss, so just gluing something behind the ear, and give them an impression of what it would mean to have a hearing aid. But also in cases where you basically have more pronounced conductive component, this could be also an option, at least an intermittent option. And it's very simple to use, and so the patient basically can try it. So that's what we found also as an upcoming alternative compared to any kind of invasive implant.
I mean, in Birmingham, we don't have a lot of experience with the adhere for adults. Certainly, my understanding is that the patients really need very good bone conduction hearing to use that sort of solution.
That's true. That's true.
Yes, in our experience, the idea is the more often a good solution for children to wait to have the age for a implantable bone conduction device, and it's better accepted than a headband all the day long or in the school, and in that case, adhere is a good solution.
It's a very important remark you make, I think, and I totally agree with you that it is a viable alternative. The thing you also need to take into account is the fact that on the adhere, the regular devices compared to the regular devices from Oticon and Cochlear are fitted. Normally, if we fit a soft band for children or a headband test in adults, then we tend to use the power devices because of the fact that you have this transcutaneous loss that you have to overcome. So these power devices, they are not suitable. They're not available on the adhere. So it is indeed, if you have good bone conduction thresholds, exactly like you're saying, Peter, then it is a viable alternative, at least for certain indications. But it's not powerful enough to be a real competitor for the power devices which you can wear on a soft band or headband. And percutaneous, of course, is the audiologically speaking, because you have more aspects to consider, of course, and you need to make a trade-off maybe. But from an audiological point of view, the percutaneous outcomes are, of course, the best.
John, are there any more audience questions at the moment?
John, you need to unmute. You're not unmuted.
I'm just looking at ones. Do you have a protocol for informed consent in your otology surgery team? Do you give the alternative non-surgical approach for the problem? I think we've possibly just covered that to a certain degree. That's again from a question from India. I think we all have a protocol. I think we'd all agree that, wouldn't we? Does anybody not have a protocol for consenting? No. Okay. May I find out what criteria you would use to decide between a BAHA and a bone bridge besides just an audiological one? Would you always offer both to patients?
Okay, it's an interesting one. I mean,
on the audiological
Nils, do you want
point,
to?
We always offer both.
On the audiological point, indication overlap for large part. The only way is that the lower limit for bone conduction for the bone bridge is at 40-45 decibels, and a powerful Ponto BAHA can be used with bone conduction down to 55, even more for super power, but mainly 55. The difference is that the range for percutaneous bone encoding device go lower for the bone thresholds.
But that's what the manufacturer says. So it's not real life. We have this data also collected, and it's normally 30 dB. That still gives you enough headroom for the dynamic range. And of course, the percutaneous with the superpower gives more to shake the head. But still, when you look on it, what the upper limit is, you need enough dynamic range in order to give the patient better speech understanding, not to hear the tones. So I'm a bit skeptical about this data on 55 dB or so, which probably is not what you, 55 they hear tones, but you need another 25 dB in addition to it. So they never go up to 80 dB maximum power output, which would be needed for getting at least 25 dB dynamic range.
So can I just check, Thomas, the 30 dB threshold, is that for a conventional percutaneous implant or for the bone bridge?
It's for the bone bridge, and for the conventional it probably is 35 or so. I mean, you have the superpower, they did do better than the other ones, but when you look on the dynamic range, on the frequency transfer function, you also have to keep in mind on which frequencies we are looking on. And especially when you look on the high frequencies, which are important, then you see that these devices don't provide the necessary MPO for speech understanding as you would like to have it.
So would you offer both options to a patient, assuming their bone conduction is 30 decibels
or
better?
I would say the bone conduction is good as long as we have a certain inner ear function. But once that is succeeded, then we should go for the acoustic implant, for the acoustic implants, as we said. Sorry, and because they give you more power, more headroom for the dynamic range. So as we discussed in the previous panel.
Okay. Myrthe, do you have any comments on this?
Yeah, thank you. I think it's important to take all the aspects into consideration. Of course, the audiological point of view is very important, and the bone bridge is, of course, an active transcutaneous device, so it's indeed a viable alternative. On the other hand, the surgery is larger, so you have more time-consuming surgery. You have a little bit more risks. You have of course, the MRI issues afterwards more than with a percutaneous implant. And you have the costs. And of course, that's also dependent in which country you live in, how the rules are, so to speak, with the insurance companies. But in our country, we do see that we generally have the patients, they come to a choice where they choose for the percutaneous instead of the transcutaneous active devices. So whether this is pure an insurance issue or a country or culture issue, I think a lot of aspects are part of this decision making. And as long as you counsel the patients in a complete way and you provide them with all the pros and cons and you have the shared decision making, then I think it's you can come to one choice or another. And of course, both the devices are good choices, but you need to make sure that the patients are aware of all the aspects.
So we've got one that's come in here from Honey Ashok, and I suppose this is the $60 million question. What options would you as clinicians give to a patient who's undergone bilateral modified radical mastoidectomies, so that's open cavity, and has had bilateral moderate to moderately severe conductive hearing loss? It doesn't specify whether these are dry ears or whether there's any middle ear space, but perhaps we could cover that one. Impossible to answer, I suspect, but yeah.
I think going back to my very first point, really, would, if feasible, an air conduction hearing aid trial would be my first port of call, and then looking at bone conduction devices following that, and in bilateral disease with bilateral hearing losses, bilateral implants would be on the table for us here in Birmingham. Thibaud, do you want to give us your view on that?
Yes. If the ears are stable and their bone gap inferior to 30 decibels, then the first option is air condition. But if the air bone gap is superior to the 30 decibel or the air unstables, a bone anchored hearing device is a real good first choice because it will cure the bone conduction component of the hearing loss. And also it will stimulate both ears. That means with one device, you close the air bone gap of the two ears. And the best result should be with two bone anchored hearing aids. In my experience, there is few patients going to two bone anchored hearing aids because the majority is happy with just one. But each time we implant a second bone anchored hearing aid, there is a gain compared to the best side, 10 decibel gain for pure tone thresholds and for speech recognition in quiet compared to the best ear. That means each time the bilateral implantation improves the hearing of the patient.
I entirely agree with that. Nils, do you want to comment on this topic?
No, I think it's not a easy question to answer because you need more information about the ears. First point, is it possible to wear conventional hearing aids? And the second point, are the ears discharging? Are there always problems with those ears? And another possibility in radical cavities would be what we do quite frequently is a subtotal petrosectomy with a blind slack closure of the outer ear canal and fat obliteration, and then we go for an acoustic implant, especially if you have a combined hearing loss on both ears, because as you've mentioned, if you use a bone anchored hearing system on one side, then you have I don't know if you want to call it advantage or disadvantage, that you hear it on the other side as well. And so if you want to really use both ears, then we would probably go or counsel the patient to acoustic implants, if conventional hearing aids or middle ear surgery isn't possible.
Right, so it's inevitable that there would be a difficult Brit somewhere. Our good friend Professor Chris Rain up in Bradford surfaced again and made a very sensible comment, which I suspect happens in a lot of your clinics. Don't you feel that a combined MDT clinic is essential, together with audiological colleagues, so that you can choose the most appropriate device for your patient?
I think it's a very good point. And you know, we certainly run a combined clinic for all the patients that undergo any hearing implant surgery, so that they're counselled together with the audiologists, and a joint decision is made with the patient about what device or solution is chosen, even if it then ends up being, you know, conventional middle ear surgery for some patients. But I think it's a very good point, and I'd entirely agree that that's an important factor. What about the rest of the panel, Thibaud?
Yes, and you can be pragmatic. That is, very often we ask to the audiologist to test a patient with air conduction hearing aids versus bone conduction hearing aid on a headband, and to perform pure tone threshold, speech audiometry in quiet and in noise with both techniques, and then the patient can choose, knowing the hearing result, the disadvantages of surgery, etc., etc. But you can explain the patient and compare the hearing result of both technique when the tests were performed before by the audiologist. It's very interesting, and we often send the patient to the audiologist to perform the test to determine for hearing what should be the best technique.
Thank you. Myrthe, do you have any comments on MDTs in the Netherlands?
Yeah, I think it's a very important topic as well, to work and to collaborate really together with your audiologist and to work in a team. For the ones that are having the conventional indications, like we discussed before, we have some sort of a one-stop shop way of visiting our outpatient clinic. So in this visit, they get in the same morning an intake in the audiological department, regular audiometry testing, then visiting the ENT surgeon and the audiologist after they have trialed the headband with both the types of devices, so they can make an informed choice which one of the types of the companies, which device they prefer. And especially if they have a conventional indication, they are most of the time able to make a decision the same morning, and then they visit our nurse, providing them information about the aftercare, and then if they choose for a general anesthesia, which they normally don't, but if they do, they can also visit the anesthesiologist. So they have just a complete circle of approach, multidisciplinary approach, and they get complete information. But for the ones that are having a more difficult indication, like the unilateral conductive hearing losses or single-sided deafness, or the ones that also having a bilateral conductive hearing loss, but still are not able to make a decision in the same morning, of course, we prefer to give them a prolonged headband trial for at least 1 or 2 weeks before they make a decision. And especially in the case that was mentioned, the bilateral radical cavities, provided you have bilateral bilateral good bone conduction thresholds. We indeed also believe that bilateral application is providing benefit, just like Thibaud was mentioning. We really have the same experience that 1 and 1 is 3 sometimes, so to speak. So the bilateral application really provides more benefit than we tended to believe in former years.
Okay, I think, Peter, we've sort of slightly exceeded our time. It's been a fantastic session and really a fantastic day, a huge success and a great tribute to Wilco and Robert Vincent.
Absolutely.
And I'd just like to ask Thomas Lenarz if he wouldn't mind summing up this session and the day for us. Thomas, perhaps you could do that for us.
Okay, well, thank you much for everybody, to everybody for organizing it and putting together this panels of experts. Of course, thanks to the panelists sharing their expertise among us and also with the audience. And I must say we had a bit of a humble start, but then we became better, even though we had some technical issues here in Hanover, but that has been all overcome. So it's great to have this kind of format where we really exchange expertise and have a in-deep discussion. And I think it really highlights where the standard of care is. And we also see where we have controversies across countries, but also where we follow different concepts, but also where we agree. And I think that's a very good thing that we achieved today with this kind of global undertaking enterprise with Lion. And I think something worth to be considered for future meetings in one or the other way. So again, we had a very full day with different topics on implants, but I think it shows where otology also has developed with the help of technology, and where we also see changing indications, new opportunities to treat our patients, and also that we really can exchange this information across continents. Very important thing, not only during COVID-19 times, but also beyond that. Well, that's all what I want to say, and thank you to everybody, especially Utrecht, to Wilco, the master of disaster. He has managed in a terrific way, to our two colleagues from UK who basically were there all the day and helping out wherever it was necessary. Thanks a lot, and I think it's an applause to you.
Thanks very much, Thomas. I mean, the good news is that it's all going to be repeated tomorrow. The bad news is that the three colleagues from the UK, amongst others, will still be there. I mean, tomorrow is looking like a very exciting day as well, concentrating perhaps more on the middle ear. If we have figures like we've had today, it'll really be a first. It'll be very exciting. So thank you again for everybody today. Peter and Myrthe for doing the graveyard shift. Wilco's off now to break open some beer, hopefully, and relax. Yeah. And we'll all meet again tomorrow morning. Wilco, do you want to say anything?
Of course, I want to thank Cor for coming here, and that by itself is quite an endeavor. It's very nice. Thank you, of course, Hanover playing a leading role today with the whole day connection. It's good to know that the connection was flawless. Of course, I need to thank Ian, Chris, and John, and everybody. And it truly is about Doctors United. Of course, there's the medical theme that we're discussing, but what's maybe even more important is also that the brotherhood, as sisterhood in some cases, the brotherhood that we have, and that we don't collapse under the current pandemic. Thank you very much. Hope to see you tomorrow. And Thomas, sorry, Bruce, but Bruce is gone. Sorry that I didn't do slides. And Cor, thank you very much for risking also the risk of infection or whatever. Thank you very much, and see you tomorrow.